Okay, so I have no conflict of interest related to this presentation. My case here is about an 86 years old lady. She's very small, a height of 155 centimeters, 53 kilograms in weight. She is hypertensive, diabetic, and dyslipidemic as the usual risk factors. Past medical history included COPD on inhalers, and she presented with severe aortic stenosis, a pressure gradient of 86 and a mean of 52, a very tight mitral aortic valve area of 0.6, and as well as mild calcific mitral stenosis, mild mitral regurg, and a good LV function. Symptoms were one attack of dizzy spell in addition to her dyspnea, NIHA class 3, but no previous syncopes. So the heart team meeting related to the age and characteristics of the patients was to send her for TAVI. During preparation, this is the multi-slice CT analysis of the patient. We have a smallish annulus averaging around 20 millimeters in diameter. She has a capacitant sinuses and a very adequately located coronary arteries, very nice height of the coronary arteries. She had not particularly horizontal aorta that you expect from such an age, but the problems comes here from the peripheral angiography, and as you can see here in the descending abdominal aorta, it's nearly subtotally occluded with an extensively calcific plaque. Let me take you back to the aorta. As you can see here, near total obliteration, despite the fact that we get some channels among the calcium, but here, as you can appreciate, a very calcified descending abdominal aorta. Also, I'd like to grab your attention, the relation between the IVC and the descending abdominal aorta is also relocated to the near the calcific part, so a bit of hostile descending aorta as well. So this is a patient that needs a non-transfemoral access for the TAVI, and as we know from the previous studies, this ranged around 24 to 30% in different registries, and although it is falling due to the recent smallish caliber devices, it still ranges in the range of 10%. Although they have a higher burden of comorbidity and frailty. So we had to consider different axes, transcarotid, transaxillary. Transcaval, as you saw from the CT, is a bit also inaccessible, or direct aortic access that was also very difficult due to the calcification of the ascending aorta. So we opted for transaxillary because it is non-inferior, it is a mostly safer procedure, a little bit of complication in previous studies, but in terms for the percutaneous versus the surgical access, it is not inferior to the surgical cut down, and this is because the transaxillary artery is usually 6 millimeters in diameter. It's easy to insert. It has faster insertion time, lower bleeding risk, easy to ambulate the patient after the procedure. Is less frequently disease in a patient with extensive arterial disease like this one. You have percutaneous bailing options in case you had any complications. Also, it is easy to teach and technically not challenging. Although there is no dedicated transaxillary equipment, you will end up with a valve, very long valve, while you need a short distance inside the body, so we don't have a dedicated equipment. Most of the interventional cardiologists are not familiar to the anatomy of the artery, as well as it needs a special room setup. And this is just to remind you the anatomy of the artery, of the axillary artery. We actually target this particular segment below the pectoralis minor and segment 2 of the artery that starts by the thoracoacromial vessel and lateral thoracic, as you can see here, and ends by the third segment here. So it's a very nice segment without any special or dangerous branches, and this is where we can target. It's also compressible, so in case of any complications, you can compress the vessel. It's far from the brachial plexus and have a low risk of pneumothorax. This is an intravascular angioscopy image, and just to show you how compressible the axillary artery is. And so in any bleeding complications, you can just press against the thoracic wall and you are safe to continue management. Also, the subclavian and axillary arteries are a little bit thinner than the femoral arteries, and we have to take this into consideration while using the closure devices as well. So our strategy was to go for bilateral femoral access, of course ultrasound guided, a carotid protection with the Sentinel device, Sapien 3 Ultra, 23 millimeter, sorry, it was a 20 millimeter, and left axillary access for valve implantation, right access for carotid protection, and we will use a single pre-closed pro-glide under a dry seal situation. We had to change the room setup a little bit, getting the screens behind the head of the patient just to allow all the team on the right and left of the patient to have adequate visualization of the screen. And as you can see here, the anesthesia at the head, 2 teams of operators, one on the right hand, one on the left hand. And we started with angiography, and as you can appreciate here, the anatomy of the abdominal aorta is very hostile, albeit we have a very nice axillary artery. Sentinel was inserted, as can be seen here, and then we started to pass a wire, and this wire, actually safety wire, will remain there from the beginning till the end of the procedure. We had ultrasound-guided cannulation or insertion of the axillary artery exactly at the segment 2 that we have just described. And here you can have also a landmark, as you can see here, the wire that we have just inserted inside the axillary artery. Then we do the puncture, pass the wire. We have the pigtail from the femoral. We do the usual shots. And probably because of the orientation of the screen and the co-worker angle, he pushed the LV wire a little bit more, and this, as you will appreciate in just a minute, had some hypotension of the patient after we placed the Safari wire, and the patient got some pericardial effusion. And for that, we had to insert, do pericardiocentesis, put a pigtail, and then we continued the procedure as usual. We inserted the Sapien 320 from the sheath and placing it into the ascending aorta, where at the ascending aorta, just above the valve, we had to reposition the balloon inside the valve due to the short distance, and then we advance the valve as usual positioning, inflation of the valve, and this is the final valve, as you can see here. And then dry sealing technique, just whenever we remove the sheath, we inflate the balloon. We do the per-closed pro-glide single under balloon inflation, so you have actually a dry field with no injection, and this is the angiography at the end, very nice with some constriction from the pro-glide, otherwise no bleeding with very secure hemostasis. So my take home for you is that percutaneous axillary access is feasible, though requires some care. It can be complementary to the armamentarium of other alternative access options. And thank you so much for your listening.